Good afternoon, and thank you for joining the Fielding School of Public Health's Continuing the Conversation webinar. Today we are thrilled to have Dr. Jonathan Fielding, Director of the Los Angeles County Department of Public Health, to discuss the opportunity costs of healthcare-related spending. Nearly a quarter of all expenditures in the U.S. are for healthcare. Yet, despite the huge sum, approximately $2.5 trillion in 2009, our spending is not producing a good return on investment. Our health outcomes are much worse than those of other developed countries. The Institute of Medicine estimates that we spend between $750 to $765 billion in excess of what we should be spending to achieve our current suboptimal health outcomes. Before I turn it over to Dr. Fielding, I want to point out the chat window in the bottom left-hand corner of your screen. If you have questions during the presentation, please type them there, and we will address them during the question and answer portion of the webinar. We will allow plenty of time for questions. Let's get started. Dr. Fielding.
Good afternoon, everybody. It's really a pleasure to be with you, and I'm looking forward to talking with you and answering your questions as well as providing some information. So we're going to talk about the opportunity costs of what we spend currently in the U.S. And what does the opportunity cost mean? Well, that the open-ended, the spending that we have in medical care takes resources from the other things which we're interested in doing, not just because they're good things to do, but because they provide greater economic value and even have a greater impact on health than some of what we're spending. The $2.7 trillion that we spend on health care is almost $8.7 thousand per capita, and that's a roaring 18% of our gross domestic product. And unfortunately, the kind of returns we get when you consider this, and we should consider it an investment in health, don't yield the kind of returns that we would expect or that other countries are getting. So unfortunately, we're both overspending, and based on what we're spending, we're not getting the return, so we're underachieving. If you look at this slide, you see that one would expect with increased expenditures that we would have better health measured in the crude way, at least, by life expectancy at birth. So you see all the way down from Korea at one place to Norway at another, and you can see that there's roughly there's a reasonable curve, and you can see based on our spending where we'd be expected to have a life expectancy of well over 81 years. Instead, it's 77.6 years, and that this differential is really the fact that we're not getting a good return on our investment. Now, sometimes it's good to be number one, but maybe it's not so good to be number one in health expenditures, not just per capita, but as a percent of GDP. And this is for all the developed countries, and you can see them arrayed there. And they go from a low of, if you look at Turkey and Mexico, they're spending roughly a third of what we are as a percentage of GDP, much less in terms of total dollars. But you'll also find that the average for these countries is about where Japan is and Sweden is, which is about 9.5%. And we're almost double that. So we are spending considerably more, and we have to ask what we're getting for it. And when we look at infant mortality rates, which is one of the measures that's usually used to consider how we're doing, unfortunately, we rank 31 out of 34. And you can see how that other than 3 countries, we are at the bottom, and we're lower than the Slavic Republic, than Austria, than Greece, Estonia, Portugal, Slovenia. So we are not in an envied position, and this has real terrible implications because it's not just an issue of infant mortality; it's the outcomes of birth. And birth outcomes, if they're not good, translate into really problems, significant problems later on in the trajectory of life, both as a child and as an adult. Well, let's look at the other measure, which we've talked about a little bit, which is life expectancy of birth, and I mentioned where we were, but this is only 27th out of a total of these 34 countries. So once again, we don't look very good, and most of the countries that are developed really compare much better than we do. We have a long way to go, in this, and unfortunately this has been the case for many years, probably decades. So the Institute of Medicine, part of the National Academy of Science, had a group, brought a group together, and they put out something called the Healthcare Imperative, Lowering Costs and Improving Outcomes. This was in 2009, and at that point, they estimated that we waste as a nation between $755 and $810 billion each and every year in medical care costs. And those were dollars that were 4 years ago, and you can be sure that the dollars today would be much greater than that, and we'll have to do some adjusting for that. But let's just take this as a baseline and ask, what are the components of the waste? The greatest is the unnecessary services, medical services that are not necessary. You can see that that's about $227 billion. Next are excess administrative costs, and everybody talks about these, and they are important, but you can see they're not the majority. They may be maybe a quarter of the excess cost. After that, you have the inefficiently delivered services which could be delivered much more efficiently than they are now. And then there are prices that are too high, another $114 billion. And then fraud, $81 billion, and misprevention opportunities, another $60 billion. Now, one of the interesting things here is you hear everybody agrees that we need to reduce fraud and abuse, and that's all the things sometimes you hear in Congress. But that's a very small portion of the total excess. It's inexcusable, but we're not going to get to where we want to get in terms of spending just by focusing on fraud and abuse. Now, why aren't our outcomes better? What are the reasons? Well, one is we overdiagnose and we overtreat. We overdiagnose cancers, many false positives. You've perhaps recently seen the recommendation of the U.S. Preventive Services Task Force on PSA screening for men for prostate cancer, which is not recommended by them, at least as a routine basis. We also have underuse of effective services like pneumococcal vaccine, which significantly reduces mortality rate in older individuals as well as in children. And then we have excess use of costly procedures, tests, and therapy. And the incentives are on the side of the provider and not necessarily on the side of the patient, because we have a system that pays in large part for procedures, and so the more procedures, the more reimbursement. And we also, I think, have fueled a set of unrealistic expectations among the populace. We have said basically almost that death is optional, that no reason you shouldn't live almost forever if you just have the right medical care. And that's not the right mindset, but unfortunately there have been a lot of forces that have kind of popularized that notion, because every innovation is touted as if it's an incredibly life-prolonging innovation, and in most cases that's not true, and in many cases you have impacts that they don't talk about the side effects or the downsides. So the most important point here is that medical care is not, I want to repeat, is not the primary determinant of health at the population level. This is a slide from the county health rankings put out by the University of Wisconsin with funding from the Robert Wood Johnson Foundation. And you can see here what they estimate to be the relative contribution of behaviors, clinical care, social and economic factor, and the physical environment. And note that clinical care, which includes both access and quality, accounts for about 20%, or one-fifth of the total. Larger is health behaviors, tobacco use and diet and exercise and alcohol and unsafe sex among them. And then you see that social and economic factors, which are the root causes of health problems in many cases, are not really being invested in nearly as much. But those issues which affect health are employment, income, education, social support, community safety, and then of course the physical environment, where we live and work, the nature of that environment, the availability of fast food, all kinds of things. And so if you look in general, the key point is that 50% of the determinants of health are related to our social and our economic and our physical environments. and realize that economic environment is really part of our social environment, because we make decisions about what incentives we're going to have and what we're going to tax. And we know that other things other than health care have great effects on health. Let's just look at formal education. And what you see for both men and women is a monotonic relationship between years of school completed and life expectancy. And the differential for women is about 5 years, and for men is about 7 years. So we're talking about huge differences based on educational attainment. It's not only for our generation, it's an intergenerational issue. So if you're a mother and you have completed you haven't completed high school, look at how much higher your infant mortality rate is per 1,000 live births. It's above 8 compared to roughly 4 if you have been a college graduate or more. So, and once again, you have a clear monotonic relationship. The more education, the better likelihood that your child is going to not be a victim of infant mortality. And then we also know that family income affects self-reported health. Once again, this is from that same report. This is report Overcoming Obstacles to Health, and this was the foundation. This was the foundation grant to the Commission to Build a Healthier America, which had a lot of bipartisan representation. You can see once again that the percentage who say that their health is fair or poor is directly related to family income, not surprisingly. But if you look at many diseases, you see the same pattern. So once again, income affects these diseases. If you look at diabetes and coronary heart disease, you see big differences in percentage affected of adults with diabetes, for example, almost a twofold. There's a little more than a twofold difference in frequency, and then you also see a 50% difference in terms of adults with coronary heart disease. So the difference between having less than 100% federal poverty level income and having 400% or more is huge in terms of health, measured in both disease frequency, disease burden, and mortality. And we think in public health often of the issue of equity, and there is no doubt in our view, and certainly in my view, that everybody deserves to have health benefits. But improving health is not just a matter of improving access, as sometimes is alleged. Access is critical, and I think it's personally a moral imperative, and we're making progress with the ACA. But that will not do it alone. So the issue is one of productivity and competitiveness. We're 5th on the Global Competitive Index, and we're only 42nd on the health and primary education component based on this report from the World Economic Forum. That does not look very good for our future, because we're talking about the education that's going to lead to productivity and competitiveness. And there are adverse effects of poor performance in our medical care system linked to our federal debt problem, because, for example, Medicare, if they're spending too much and inefficient, it's going to add to our federal deficit, as in fact it does. Now look at the states also. In 2011, Medicaid alone accounted for roughly 1 out of every $4 in state spending. And in 2011, it was up 10% over 2010 costs, despite the fact that inflation was extremely low on other goods and services. So states are incurring additional health expenditures, both for their current employees. Retiree health is one of the biggest issues on their balance sheet. Prisoner health, a huge issue, particularly here in California, but elsewhere as well. And you can see that, and often the states, I think without exception, the states are the largest employer in their state, so it has an effect on their employees as well as the programs that they provide. So the real key point of this presentation is that, and nobody talks about it, is that the amount we spend on medical care crowds out, does not leave room for other valuable expenditures, such as higher education, but early childhood, primary and secondary education as well, job training, economic development, adequate housing, and maintenance of critical infrastructure. we invest inadequately in the social programs. And we do, but if you look overall, you'll see that what we spend overall in social services, if we include health services, is, reasonable. It's not at the top of the list. It's significantly below Sweden, which is way off the chart, if you will. And some of these other countries that in Western Europe that have had other kinds of problems but spend a lot on social programming, like France, Switzerland, Belgium, Denmark, and Austria, and Germany. We're not spending as much as they are, but we're in the middle or to the top third or so of the pack. But what's really important is that we're spending only that 13.3% on the social programs other than health benefits. Much, much less than all of these other countries, because the countries that are close to us are spending 50% more than we are as a percent of GDP on those other programs. And the reason we're not spending it, one can argue, is because we're overspending in healthcare. There's a limit to how much people are willing to be taxed. So what are social services? Well, income supplements, income security, assistance for housing, coverage for unemployment. There's been a big fight about benefits, child care, care for the elderly and disabled, which is growing at an exponential rate because of the aging of our population, survivors benefits, job placement services, employment training, and also food subsidies. I'll talk a little bit about some of these. So what is a dividend? A dividend is a benefit from any action. And it's usually something that is not just a one-time, it's usually recurring and often annual. So when you buy a stock, you expect, in many cases, an annual dividend. And we have a dividend that we could get from reducing the waste in our healthcare system, the overall of the $700 to $750 billion. And about 55 of that savings or waste accrues to the private sector, which is over $400 billion. Those are private employers, the business interests, the voluntary sector. The remaining roughly half, or 45%, is the federal and state, and to a lesser degree, local governments. It's basically in the public sector. So wouldn't it be great if we could just wave a wand and say, oh, we can get rid of waste very easily? But unfortunately, that's not true. But the question really is, what would we do if we could eliminate it and use it for other high priority investments? What would be the impact? What could the $750 billion do? Excuse me. On the private side, we could greatly increase business investment. We could add jobs. We have the highest unemployment rate in the nation in California, over 10%. We could add jobs. We could increase our international competitiveness at a time when it's really critical to our economic development. We could bolster our growth. We could increase wages. We could increase leisure, and we could increase consumer purchasing, which would further stimulate our economy. So all in all, it would increase our living standards. On the public side, we could stabilize our deficit, which has been growing at unprecedented rates of over $1 trillion a year. We could also improve the failing infrastructure, the highways, the bridges that are not in best repair. And we could improve the overall well-being of our overall population. So the health dividend is really a large stream of resources in both the private and public sector that could be freed up without having an adverse effect. Isn't it amazing that we could spend $750 billion a year less and not have a bad effect on health? In fact, the effect would be in the positive direction because we would have better investments. Now, there are almost an infinite number of ways that we could take and spend this health dividend, but let's just take one scenario and let's focus on the public sector. So this is that 45% to the public sector, and this is arbitrary, but I think it's illustrative and helpful. So if we took half of that and said that's going to be on the federal side, and that's going to be for fiscal stability. And then we'll take another 30% and say, well, that'll be social investments in government at all three levels. And then another 20% and focus that on improving our failing infrastructure. Let's see what we could get for that. So if we took half of that as our fiscal stability investment, that would be $168 billion annually. And you would see that, look at this is our, by the way, our national debt. This was, almost 2 years ago, and it's grown significantly since then. And you can see that for every family at that point, there was $120,000 of national debt, which has to be paid back, and that has a drag on the economy. So let's say what we could do with this. If only half the government share of health dividend were applied towards the federal debt reduction and for the next 10 years, we would have more than $1.5 trillion less in debt. This is roughly the amount that the 2011 Congressional Super Committee was not able to solve. They were aiming to reduce it by this much, but they weren't able to. We could do it in just easily with a minority portion even of the savings from the health dividend. Well, let's look at social investments. Let's just take 30%, and let's just see what those might be at $104 billion. Now, what is social investment? Well, those are social programs in many cases that have demonstrated that they can improve health, improve quality of life, and further economic outcomes. Here's some examples. So we could get better graduation rates, lower uses of substance abuse, less violence, and lower rates of teen pregnancy. We also note that social programs are labor intensive. They employ a lot of people to do these kind of programs, and therefore this would benefit job growth in a very positive way. So here are some of the things that we've thought of that all could be paid for with that roughly $100 billion a year. And we'll go through these, but you can see they're quite diverse. Let's look at reduced class size. That's about half of the money. And all 24 million elementary students could be in a classroom that would have 13 to 17 students instead of the average of 22 to 25 students. And that class size reduction is estimated to yield between 70,000 and 140,000 additional high school graduates every year. And you know the health benefits and the quality of life benefits of that. And also additional benefits means more tax base, because over a lifetime, every time you have a graduate, you're going to get in taxes $287,000 more. And you can see at every level of education that goes up, so that if you have a master's degree or higher, you're going to contribute on average over $1 million to the tax base. At the same time, every time somebody drops out of school, out of high school or middle school, you're going to lose almost $300,000, because you not only get lower tax revenues, but you have higher cash and in-kind transfer costs, the kind of benefits, the social benefits that they need. We also have higher rates of incarceration. So we have a lot of differential between the 1.1 million with a master's degree and the minus $292,000 for a high school dropout. We're almost talking about $1.5 million difference per person in tax revenues and expenditures. Now, what about a smoking prevention campaign? We know that campaigns like the Very Effective Truth campaign, funded at this small level, now we're just talking about millions, not billions. Even $100 million could prevent 300,000 students from smoking and save nearly 3 million life years. What about home visits from nurses? These are very effective programs. They're evidence-based. If we took 4.2 billion, we could do home visiting for all 700,000 pregnant smokers and pregnant teens. And we could reduce the number of low birth weight babies. And we know that low birth weight increases risk for all kinds of complications. And we could reduce ER visits associated with that by almost 500,000 during the first year of life, further reducing the demand for healthcare services. Now, what about social development? There's a very interesting program in Seattle that could be widely disseminated, and that would cost about $14 billion a year. This was a multi-year school-based intervention. It's been around for over 30 years, And what it did was focus on increasing the children's bonding with their families and with the schools. So teachers were trained in classroom management, interactive teaching, cooperative learning. Students were taught problem-solving skills for interpersonal relationships, and also refusal skills to avoid personal behaviors such as unsafe sex or early sex, such as use of substances, of illegal substances, and the like. And parents then were offered courses in child behavior management skills, how to support their children, academic support, which is extremely important, and particularly in lower income families, and skills to reduce their children's risk of drug use. Here's the results. When you look at age 18, when you compare the control groups and the participant groups, you see major impacts, particularly in the percentage that have to repeat a grade. It reduced that by roughly 1/3. Much less likely to be involved in school misbehavior, to have been engaged in drinking frequently, to have sex or to have multiple sex partners. And look at the reduction in pregnancy, or have caused a pregnancy. So this has huge social benefits in so many different areas. Another opportunity is doubling Head Start. For another $13 billion, we could double Head Start to include almost another 1 million children. And we know that Head Start enrollment translates into reduction in childhood obesity, decreased smoking prevalence later in life, and a lot of other benefits. So again, once another opportunity with relatively small expenditures compared to the savings available from healthcare. You've probably heard about preschool education. If you just did a half-day, year-round preschool, for those not in Head Start already, you could see significant long-term gains in cognitive ability and socialization, which we know can translate into further achievements, whether you're talking about high school graduation or you're talking about social adjustment or reduction in contact with the probation system, with the child, with the juvenile system for behaviors and the like. Well, let's look at teenage pregnancy prevention. Very important. Again, a relatively small expenditure, 1% of what we're talking about for this category. And for $1 billion, all junior and senior high school students could receive an effective teen pregnancy prevention education and counseling, and to the degree necessary, clinic visits. And that could reduce pregnancies by $45,000 a year from teens. So, excuse me again, and we're talking about a very substantial reduction. And we know that teen pregnancies not only retard what the mother's educational attainment is, but are not necessarily the best way to start life for a newborn. So we've talked about two categories. Now let's talk about the third. This would be the smallest category, 20%, for infrastructure investments, $61 billion a year. Well, what could we do with that? Well, this would have huge benefits in communities, both in the natural environment and in the built environment. Think about more green spaces, more parks, cleaner air, more affordable public transportation, all big issues here in Los Angeles, but big issues nationwide as well. Here's just one example from Charlotte, North Carolina, of light rail use. And when that was put in place, it led to a reduction, which is quite meaningful at a population level in body mass index, and an 81% reduction in the odds of being obese over time. So mass transit, because you have to walk to it, and you know, you're not just getting in your car in your driveway and then or in your garage and going to work and coming back, leads to very significant improvements in physical activity, and that translates into reduction in obesity, but also often better quality of life. So here are some possible infrastructure investments. I won't go through all of them in detail, but you can see they're quite diverse. And let's just go over just a few of these. 30 years ago, not that long ago, a generation and a half or a generation, over about 2/3 of American kids walked to school. Today, it's down to 13%. So one of the investments we recommend could be safe routes to school for, again, not a huge amount of money, $1.2 billion. We could have safe routes to school for every primary and secondary school in the country over the next 10 years. And initiatives have shown that as many as 30% more students walking or riding bikes to school, with a reduction in the need for buses and certainly a reduction in vehicular traffic around school, and much better physical activity outside of school hours. What about public libraries? Libraries are still important, and we know that they improve the quality of life. They are a place for social interaction, and they in fact are good at having useful and productive activities for children and teens. This is the Seattle Public Library expansion. It's a model, and if we use their model, we could reach about 31 million beneficiaries over 10 years. But now, through their initiative, they're up to 94% of residents that have a library card that had circulation based on having library cards. The public computer access was way up, and they were using the programs that seemed to make a lot of sense, such as computer classes and SAT prep. All those have increased. Well, water, in my view, is probably going to be the biggest issue of the 21st century, and one aspect of that is improving waste and stormwater treatment to get better water quality and to reduce waterborne gastrointestinal illness. And living right on the coast as we do, this is right up our alley. We know that we can do a better job with creation of overflow sewers, better rainwater storage, buffers between the hard surfaces and water bodies. And again, this is not a huge expenditure. It may be, in fact, a little understated in terms of what we may have to do, but it could make a big difference. What about career training? I think one of the things that we've most missed through attrition over the period of the last 30 or 40 years is vocational and technical training. This suggests that if we spent $18 billion, we could do career training for 1/4 of the unemployed. And we've found through successful programs that 27% of those who earn a vocational license, think welding, think plumbing, for example, or a certificate after high school, earn more than the average wage for those with a bachelor's degree. So one of the things we're lacking is sufficient people with the technical skills and the vocational skills, and yet we're not training them. And a lot of for-profit organizations have made a lot of money there, but not necessarily had the best outcomes. We need that to be something in the public sector. And this could be done very effectively for $18 billion. And many other countries have these programs, and it makes a lot of sense. What about small community grants? So this $750 million, less than $1 billion, could provide community facility grants and rural economic grants to every small town in the U.S. over a 10-year period. And those really do have an impact on quality of life. They reduce the geographic disparities, and they promote social interactions and healthier lifestyles, again, with not a huge amount of money. There can be rural economic development grants, there can be community facility grants, and you can see that they help in a whole bunch of different ways. What about the Job Corps? The Job Corps is a program that takes youth between the ages of 16 and 21 and helps them get a skill, finish their GED, and be prepared to go out into the job market. And this program has been associated with first completion rates for GED, decrease in unemployment, increase in earnings, and decrease in crime and violence among the participants, many of whom are from some of the most difficult backgrounds you can imagine. A very popular program, and one that has expanded tremendously, is Supplemental Nutrition Assistance Program, or SNAP. And for $20 billion roughly, we could cover all 50 million food insecure individuals in the U.S. Hard to believe there's another 11 million people who are food insecure than are getting help now, but it is absolutely true. Well, food is expensive. And this has, we know, direct benefits for health And we know that food insecurity leads to obesity, poor attention, poor learning, and poorer mental health. So this would be a very important investment. Transportation system improvement. This could support some components of the President's upfront transportation system. It would get highway infrastructure. You see all the potholes and areas that need help. Could support local bus and rail systems, high-speed rail, which has been controversial, but there's no doubt we need it in certain corridors, and new transit options to reduce traffic congestion, roundabouts, and the like. So here's the trade-off. Here's the proposition. On the left-hand side, it's kind of like, I feel like I'm introducing two boxers, but on the left-hand side, you have all these investments, all of which could be made with the money saved if we were efficient in healthcare. On the right-hand side, we have what's kind of eating up and assumed to be something that we can't change. So we have popular complacency about a system in healthcare which does good things, but is unfortunately not efficient and has a lot of waste. So the question is, are we going to continue that level of complacency? I hope not. What we're trying to show, what we'd like to show policymakers, is there's a significant opportunity cost, and it's not a trade-off issue of having poorer health for these investments. It's a question of, in fact, taking out the waste, the very substantial waste that puts us way off the chart in terms of inefficiency, and using that in productive ways that can improve quality of life, health, and economic productivity. And so in essence, think about it a different way. Think about it as if we have a $750 billion tax imposed every year, and we don't discuss what the alternative uses of that tax are. But it does take difficult decisions, and let's face it, the medical industrial complex is the strongest lobbying group. They're the biggest, they account for the most of the gross domestic product, and most people personally have great attachment to it. We all want a very good healthcare system, but unfortunately, to make a difference here, we need a concerted effort on the part of many sectors and government agencies and others. We need, somebody has to raise the flag and say, you know what, we are crowding out critical investments that put us behind other nations and wind up with a poorer quality of life and poorer economic development and productivity and competitiveness over time. It's hurting our standard of living, and worse than that, is consigning our kids to having a huge overhang of debt. And those interests don't come together to talk about this. But it's the time. It's time to do that, and we hope that this presentation will evoke some interest on the part of many to say, how do we get together and deal with this health dividend? The opportunity cost is too high not to do so. Thank you very much, and I'd be happy to open this now to questions.
Okay. Thank you, Dr. Fielding. You're right. Let's move into the question and answer portion of this webinar. If anyone in the webinar has a question, please type it in the chat window in the bottom left-hand corner of your screen, and Dr. Fielding will answer it now. I'll start off with a question. How can webinar participants, or everyone listening right now, how can we get involved in advocating for better investments for health?
I think there are a couple of things that are important. One is just letting people know the very high cost of not doing anything differently. I don't think people realize this crowding out phenomenon. And I don't think most people want to greatly increase taxes so that we add another $750 billion a year on top by saying, oh, well, what we have is okay. I think also most people don't recognize that the major root causes of ill health are in our social, our economic, and our physical environments. So informing them, trying to get them on your side, particularly leaders in communities and those who influence policymakers as well as policymakers, is a very important opportunity that I hope others will step up to the plate to do. Carolyn
says, thank you for such an informative discussion. When reducing healthcare waste in this framework, how is quality of care ensured at the same time?
Well, a lot of the inefficiencies, unfortunately, contributes on the other side to poor health outcomes. And we see that by the fact that we're spending a lot more, but in fact getting returns that aren't to scale. So we still have to focus on quality assurance, and in many cases when we look at quality assurance, we find overuse, we find inefficiency, we find the wrong incentives. We need to continue to focus on quality of care and make sure that we're doing the things consistent with the best evidence, which is not always the case. So I don't think we have a huge risk of reducing the quality of care. We have a significant opportunity to improve the quality of care because overuse, ineffective use, inappropriate use is not consistent with quality of care.
Thank you. We have another question. We are currently surrounded by ACA implementation. Do you think healthcare reform will solve some of this wasteful spending that you highlighted?
I don't. I mean, it may do it a little bit, but the cost containment measures, the cost control measures in the ACA are not terribly strong. So I have very limited optimism overall. I do think that a number of innovations in the electronic medical record, a number of things have some potential, but I also think that we have a continuation. If we continue with the incentives that reward more and don't really penalize overuse and inappropriate use, it's going to be hard to control costs. So I would say I'm not pessimistic, but I think that we have to be realistic about how much we can expect from the ACA in that department. It was basically an effort to improve access, and I think that's important, and there's some opportunities to further prevention. The automatic incorporation of the A and B recommendations of the U.S. Preventive Services Task Force, the Public Health and Prevention Fund, I think, is a critical piece, but I'm not sure that the absence of a direct controls on costs and limitations on increases are going to do it. Now, there is talk of trying to reduce some of these costs now. I think the mechanisms we have to wait and see, and the willingness, because we're certainly not going to get there just by talking about fraud and abuse. I'm not suggesting this administration is only doing that, but that's been the mantra for kind of decades in Congress about, okay, well, we're going to deal with this by dealing with fraud and abuse as a major part, and I don't think that works. We need to do all that, but we can't overstate the likelihood of the level of dividend that we're going to get from that.
Great. We have another question. We know that you touched upon this a little bit in your discussion, but if you had to pick one or two critical areas where investments would be most beneficial to health, what would they be and why?
I'm not sure. It's of all your children, who's your favorite? That's not always a good question. I think that it has to be a balanced portfolio of investments. I think all of these investments would be important. A lot of it is a question of political will and how strongly the folks are who can argue for their alternative investment. Obviously, some of these social programs where we in fact are deficient compared to most of our competition are clearly important. So I would think some of the social programs are important. But at the same time, I think since there's been so much focus on deficit reduction, the fact that we've been greatly increasing our deficit, doing that would help to people to focus on the interrelationship between health and our overhanging federal debt. I also think that infrastructure gives you some very tangible, obvious, visible benefits, which can help reinforce the importance of having and using the health dividend.
Thank you, Dr. Fielding. It looks like we have one more question. what do you see as the largest barriers to freeing the money to make more social investments? Do you think maybe healthcare companies, lobbies, public apathy?
I think all those are important. I think first of all, lack of understanding that how much we're overspending, and the fact that we're getting a very bad result from overspending compared to other countries that spend significantly less as a percentage of GDP. So the inherent inefficiencies and the fact that we get that our results are not what they need to be, and so those who cry doom if we spend a little less, I think that's what people listen to. Somebody says, oh, there won't be a heart transplant, or there won't be this, and I think we need some it's very hard to counter the very strong lobbies, and each group has a very strong lobby: hospitals, doctors, medical devices, pharmaco, all those. And I'm not arguing that some of what they say may be valuable, but it needs folks on the other side. It needs the folks that are interested in these other sectors and understand the benefits of more investment in these other sectors: economic security, social programming, infrastructure development, job creation, to focus on this and to say, you know what, we need to be a counterforce so that we can, in fact, get some limits on how much is spent and make sure that these other investments aren't going wanting. And they have to band together, and that's definitely not happened. So we need more consumer interest and education. We need policymaker interest in education, but then we have to in fact have lobbying which fights to in fact affect these other dividends.
Okay, thank you, Dr. Fielding. It looks like we'll wrap up our Q&A session unless I see any other questions in the chat window. But thank you so much for joining us today, Dr. Fielding. I think we all learned a little bit more on the opportunity costs of our current healthcare spending.
Thanks to all those who listened, and I hope you'll become ambassadors and share your thoughts, share these thoughts, modify them in any way you think. But we need more people to be talking about this because it is not widely appreciated and not widely taught. Thank you so much for your interest.
If any of you have missed any of our previous webinars, you can go to the Fielding School of Public Health's website, ph.ucla.edu, and they're all archived there. We'll keep in touch about our next webinar. If you have recommendations for future webinar topics, please email us at publichealth@support.ucla.edu, and we are very interested to hear your suggestions. Thank you all for joining us today again, and have a great afternoon.